So should I start? Sanjog, I'm starting. Start. Okay. So first of all, welcome to you all. This Boston Scientific Lunch Symposium, and today's my talk title is Modern PCI: Defining a New Standard of Care to Better More Patients' Life. So my title is See, Prep and Treat. So all of you know, seeing is believing. This is my philosophy. And second thing is my philosophy. What I tell my all fellows: if you fail to prepare, then you are preparing to fail. So take an appropriate decision. So let's see how I proceed. If you know the evolution history of PCI, all of you know from the very beginning, plain angioplasty, bare metal stent, drug-eluting stent, first generation, third generation. And after this concept is come forward for precision angioplasty. Precision angioplasty are for the better outcome of our patients in terms of morbidity and mortality and quality of life, developed by proper preparation of the lesion. Suppose rota, simple stenting, complex stenting, and auxiliary technical instrument will help us for better outcome like IVAS, FFR, OCT, like that way for stent optimizations. And we depends on really in real life clinical data we need. If you have the strong data, then you can make your decision very perfect in your own community. So if you look at this, sorry, if you, I just give the overview because my next speaker will cover everything. I just give you the overview. So I think you should understand actually what we need in our real life. So I just go to the Syntax 2 trial flow chart. All of you know it is physiology optimization. After stent implantation, IVAS is used and found this is the better outcome. This is the Syntax 2 flow chart trial, and they observed at 5 years the consistently and persistently better outcome after optimization group than non-optimization group. If you look at this, their conclusion from the Syntax trial 5 years, their clear-cut conclusion, physiology, guidance, PCI may help you to reduce the number of stent, and I was give you more insight for stent optimization for better outcome. And in case of CTO, you can get better result for more complete revascularizations. But very interesting thing is that 5 years Syntax 2 trial, every patient was included. Latest generation, third generation, thin start synergy study is used. So you have to take decision during your procedure. So if you look at the C, I told you seeing is believing. What is this? Someone is coming. Okay. If you look at the FAME study, all of you know FAME is very much popular, and that is carried out by FFR versus angiography guidance multivessel PCI. They showed routine FFR patient with multivessel disease undergoing PCI with DAS significantly reduce the rate of composite endpoint at 1 year. Similarly, if you look at the defined study, I think please you eat your food by your own way, keep silence. And if you look at the defined study, and it also shows at 1 year IFR demonstrated non-inferiority to FFR. So I just give the message to you, if you have FFR or DFR or IFR, whatever you have, you
Ladies and
just
gentlemen,
use.
can we ask that you keep your voice?
So if you have IFR, DFR, whatever you have, you can, any modality you can use, it doesn't influence your outcome results. So don't worry, please don't be panic. And if you look at this ultimate and IVAS trial, they also showed IVAS guided PCI much more better outcome in comparison to angiographic PCI in terms of reduction cardiac death and composite cardiac death, MI and stent thrombosis. And if you look at this Renovate complex trial, also similarly found better outcomes. And if you see why use IVAS, actually we detect the lesion length and try to understand the plaque morphology, whether it is fibrotic or calcific or mixed, and what or calcified. So, what strategy you should take and how you modify calcium management, how you make a plan for calcium management. And finally, vessel sizing, which is covered by Dr. Sanjog, so I should skip it. And second thing, post-stent workflow, how you can do, check the geographic means. Very important, especially in osteal lesion, osteal LED or osteal left main or osteal RCA. Is geographical means that may cause mishap for the next subsequent days. And geographical means, and after the procedure, you have to check it whether the age disease or not, because it is the predictor or harbinger of this stent thrombosis. So you have to be very careful for after stent implantation. You have to check whether this is age dissection or not. Check malopposition. If malopposition, it may reduce. You can reduce ISR, restenosis, and optimal stent expansion. You have to check it by IVAS. So we should use IVAS. So modern PCI starts actually from the IVAS and other tool as well. If you see, if you believe, seeing is believing, you have to see it first. After seeing, you make a decision. Yes, you have to prepare the lesion. So you prepare the lesion according to your assessment. Then you treat by confirmation by IVAS. So what is the recommendation from the International Council of American College of Cardiology? If you look at this, all cath labs should have imaging capability. And interventional imaging is essential, adjunct to complex lesion subset, especially left main bifurcation and CTO cases. Education is needed to get here, and that's why we are here today to interact with our national and international faculty, exchange our views and ideas, how to develop our settings in low-cost country like Bangladesh. So if only one technology can be employed, sometimes a lot of people are asking us, sir, what modality we should have? So is my simple recommendation, one technology if you adopt, you should adopt IVAS. Why? It is more flexible and it can be utilized in almost all clinical scenarios. So we should prefer IVAS. So how we prepared the lesion. So all of you know the calcium is the main culprit, and it is the 30% case complex PCR calcified lesion. It leads to worse clinical outcome, and it may prevent adequate stent expansion. So we have to careful about calcium. I think it will covered by Sarita, so I have to skip it. Again, just what the challenge in the pre-PCI for calcium management, adequate pre-dilation may not be done, and difficulty with complete dilatation in peri-procedure, prevention of adequate stent expansion, and post-PCI insufficient drug penetration and subsequent restenosis chance is very high. So, if you see adequately, you can prepare the lesion. Actually, what we see actually, if you look at this IVAS, either the less than 270 degree or the 5 millimeter arc of this calcium, or the focal or diffuse, or minimal luminal diameter less than 2 millimeter, not whether the balloon crossable or not crossable. So you take decision, either you go for rotablation, either you go for IVL, or if you go for NC balloon or OPN balloon like that. So if you assess, cross the IR, you can assess fine. If it is not uncrossable, then you can try to pre-dilate first, then you go for IVAS, assess the calcium. Then if it is less than more than 220 and more than 5 millimeter, you will get score 1. And if it is 360 degree calcium, score 1 is calcium nodule, that is score 1, and vessel diameter 3.5 millimeter, score 1. If score is more than 2, you have to modify plaque modification. You have to go for plaque modification. Otherwise, you don't get optimal result. So, and if need cutting balloon, it also covered by my next speaker, so I skip it. And finally, how you treat, this is my last slide. I think you should use best stent, thin stent, latest generation synergy stent or Promas Elite. If it is ISR, you can drug coated balloon, you can use it. So this is my conclusion. Thank you very much.